technical factors. Since we ended the last lecture on Wednesday on the H&D curve, this kind of bleeds into that, technical factors and contrast, exposure, and all that kind of stuff. So why don't we do that instead of doing distortion? And what I'll do is I'll take the H&D curve portion of the last lecture and I'll blend it with this, so it'll be just one thing, one video on YouTube and whatnot. So that's what we'll do. And one of the things that I did was I took the H&D curve portion and I moved it down so that it wasn't two separate portions on the PowerPoint. So characteristic curve is that thing that I drew. I think mine was much more attractive than this one.
Yes.
Yeah, absolutely. But just to review what it was that we talked about on characteristic curve, is a couple of different things. And remember, there's a number of different words for it, or names for it. It's H&D curve, the Herter and Dreifeld curve, the D log E curve. So that's density and logarithmic exposure. So it's D log E curve. What am I missing? Characteristic curve. Yeah, that's right there on the slide. Characteristic curve. So they all mean the same thing, and all it is, again, is a measure of the speed of the imaging system, which is essentially where, I'm just going to say at this point in density, where the vertical axis of the curve is, if I had two curves up here, whichever one was closest to the optical density axis at 1.0, and it's really 1.0 plus base plus fog, but that really has to do with screens of film, so it doesn't really have an application. So we're just going to say 1.0. Whichever one is closest to 1.0, that's going to be your faster image receptor, right? So most of the time, high contrast is going to be high speed, and low contrast is going to be lower speed. But they're still going to be pretty similar. And again, a more vertical curve where the useful densities, a straight line portion of the curve, those are your useful densities. And the more vertical that is, the higher the contrast is. So when you're looking at your computer algorithms with all those little lines that are going up and down, and it has one of these assigned to it, again, anything that you want to see with very high contrast is going to have a very vertical straight line portion of the curve representing that histogram lookup table. And if it's horizontal, then that's going to represent lower contrast. So the things about contrast is we can measure contrast, and if it went up, let's say instead of having all these, if this was 1, 2, 3, and 1, 2, 3, if we got the same a unit of exposure gave us 1 unit of density, so 1 to 1 would meet at a 45-degree angle, right? So that's really how your image receptors work now, is that for every unit of exposure you get a unit of recorded exposure, but it's not until they apply the H&D curve or the stored histogram that you actually get your contrast out of it, okay? But your raw image should kind of reflect that to a degree. 1 unit of exposure gives you 1 unit of density, 2 units of exposure gives you 2 units of density, and things like that. So if you're working on a system where you can turn the computer algorithm off, you can kind of display this. I know Mindy knows how to do it on her equipment. I don't know that Mother Francis has that capacity. I think they've got some similar equipment, but I just don't know that you can get into that screen to do it. So if you happen to be at UT and you're just curious, you might turn the computer algorithm off and shoot some images and see what they look like. And in that way, you can kind of better understand how it is that KVP affected your contrast, because if you use a lower KVP, it should display higher contrast. If you use a higher KVP, it should show you the lower contrast. So it might help you, it might not, since you're never going to be using films, you're always going to be using digital imaging. But if you get bored at clinicals sometimes, right? I mean, I was a student once. Sometimes you just sit around going, I wish, you hate to wish for a bus wreck, but you know, you kind of do sometimes. It's like, give me something to do. We'll find something to do, you know, go learn something. So that's, again, the H&D curve. And how our technique factors into that is totally different now than what it was with screens and films. So again, I added some color, removed the color from the slide itself and all that, but and added some verbiage and whatnot. So I broke this slide into a couple of different slides and deleted a couple of other ones that fundamentally said the same thing. So technique, exposure factor, and image quality. Remember, in image quality, we have two things. There's contrast resolution and spatial resolution. Spatial resolution is your sharpness or recorded detail. Contrast resolution is just a difference in density. So with KVP and exposure, what we get with a change in KVP, and if that's the only thing we do is change KVP, then we're going to have a direct relationship in that it goes in the same direction. That is, you increase KVP, your exposure is going to go up. As exposure to both the patient and the image receptor is going to go up with an increase in KVP. If you decrease KVP, the exact opposite is going to happen, right? So it decreases. But it's an exponential proportion. So a 15% increase in KVP gives you a drastic increase in output from the X-ray tube, but the more drastic thing is, because with the increase in KVP, you get also an increase in penetration, then post-patient, you get an exponential increase in exposure to the image receptor. So if you increase your KVP by 15%, the exposure to the image receptor increases by a factor of 2. Bingo. So it has no effect on sharpness or recorded detail. Sharpness or recorded detail are your geometric factors, and those are the things like your focal spot size, your angulations, your OID, your SID. Those things are going to affect your sharpness, actual sharpness or recorded detail. But if visibility primarily is scatter and scatter cleanup, and if KVP increases penetration of scatter and that scatter makes it to the image receptor, then potentially you could have some effect on visibility. And I'm dancing around it does, because fundamentally it doesn't that much. You know, patient thickness is going to have much more of a play on that than what KVP is. So again, you're on a slow day, you can mock up a patient. I've kind of mentioned this before. You can mock up a patient, make sure that your patient has plenty of water. So, you know, maybe find you, if you can, find one of those big square basins, right, and put some water in it, and then put something that would simulate bone. I'm not talking about plastic skeleton bone, because you know it's plastic and it's easy to penetrate, but find something else. Even if you bring something from home, you know, you're having ribs one weekend, still bring a rib up there. Make sure it's clean, but bring it up there. Throw it in the water and make an exposure. Increase your KVP and make another exposure and see what the difference between those two is, whatever. And if you're using the same computer algorithm, you know, if you push, let's say, pick anything, chest x-ray, and you make an exposure at, let's say, 80 kVp, and you make an exposure at 100 kVp, and you bring those two images up side by side, you know what you're going to see? Nearly no difference at all. You're going to have to look really, really hard to see any kind of difference. Now, if you shot it at 40 kVp and 120 kVp, you might see something, but you would be shocked at how similar it is. So a dance around, yeah, it's going to affect your visibility, because it's really not within a reasonable range. The only way that you get out of that visibility range is if you really do something drastically wrong. So you're going to have to do something with KVP and mass to make it really, really look obvious. You can penetrate a rib with 40 kVp, but and it might even look okay on the image. But at 40 kVp, what are you doing? If you drop your KVP all the way down to 40 kVp, what are you going to have to do? Yeah, your mass is going to be off the chart. So if that was your patient, what'd you do?
Just increase completely.
Yeah, you either gave them or cured them of cancer, one of the two. So, yeah, so you don't want to shoot anything with 40 kVp, but you'd be surprised at what you can penetrate with 40 kVp. So give it a try, just play around. And then take that same basin of water, you know, for your first little experiment, maybe just use, I don't know, 2 inches of water, and then fill it up all the way to the top without spilling over, and make an exposure on that, bless you. And what you'll see then is a change in contrast, or you should see more of a change in contrast than what you see with KVP. Okay, so your tissue thickness, which is not what I meant to get into today, but your tissue thickness has more of an effect on your actual contrast than what do your exposure factors within a reasonable range. So it has no effect on sharpness or recorded detail, maybe some slight amount on visibility. SID is, you know, it kind of works a little bit in the opposite direction of KVP as far as image receptor exposure goes. It's inversely proportional, so as one goes up, the other goes down. So if we increase our SID, then our image receptor exposure is going to go down. And it's exponentially related, so if you increase your distance by a factor of 2, the image receptor exposure goes down by a factor of 4. 2 squared is 4. It's exponential, right? And then what we use SID for is to reintroduce sharpness or recorded detail whenever we have an increase in OID. Right, so we increase OID, we increase SID to reintroduce sharpness or recorded detail. So where it doesn't really have any effect on visibility functions, it does have an effect on sharpness or recorded detail. And we're going to talk about that when we get into magnification and how to mitigate some of the loss of sharpness or recorded detail with the use of SID. And it seems kind of complicated. We make it a little more complicated than what it has to be because we don't use distances that are I don't know, proportional to each other, I guess would be. And what are our most common 2 distances?
72, 40.
40 and 72. If it was just 40 and 80, just that 8-inch difference, the whole magnification factor component of this would be so much easier, and we'll get into that whenever we get back from spring break. So, KVP, effect on technique, increase exponentially, especially at the image receptor. We get an increase in exposure, image quality, maybe a slight change in visibility. With SID, it's inversely proportional as far as exposure goes, and it is what we use to control sharpness or recorded detail when we have an increase in OID. If we can't use increase in SID, we have to do something else. So then we have MA and time altogether for mass. So some of this is going to kind of read the same. So in both cases, what we have is direct proportionality. It's direct in every way. So each one of those components is direct as far as image receptor exposure goes. So if you double either your MA or your time, then your image receptor exposure and your patient exposure is going to exactly double, provided your machine's shooting right? So it has, since we don't change the PE ratio with mass, that's all about KVP, there's not going to be any effect on visibility unless you really, again, do something really, really crazy. Shoot a hand with 500 mass, you got a problem, you're going to lose some contrast. Okay? Has no real relationship with density anymore, but it does have with exposure. It's the main thing that we're going to use to affect a change at the image receptor as far as exposure goes. So you make an exposure and you have to repeat it because your index number indicated you used too little radiation. Then for now, and until this changes to KVP, your answer on the test is always going to be you change your mass, right? So regardless of if you change your MA or your time, you're going to change mass. So has no effect on visibility, but it can have effect on actual sharpness. So if you use a very high MA station, you create a large space charge. Thermionic emissions are too far out for your focusing cup to keep them compressed to the right place on your anode, or the focal spot on your anode, then what you're gonna have is bombardment of your anode in a larger area than what you had before. So it's kind of an extreme example, but you know, you can see the shadow of my hand really, really well because where the light is coming from is from a very small source, right? So you can see the outline of my hand real well. But the room is lit with fluorescent lights, so you put your hand over your table and what do you see?
Nothing.
Yeah, you see an ugly shadow, right? And you really kind of see multiple shadows because of multiple lights, and every one of those shadows is not clear. It's kind of fuzzy because our sources are 4 feet long each, right? So large focal spot, ugly shadow, small focal spot, sharp shadow, right? So if we use a very high MA station or a high prep time, long prep time, then we can cause our space charge to get a little unruly, so to speak. So it's too much for the focusing cup to handle, and then when they travel across the X-ray tube, they hit the anode on a larger place than what we wanted them to, and we get a fluorescent light effect. Or we lose sharpness or recorded detail. It's not that drastic, but we do lose sharpness or recorded detail. So it can have effect on sharpness or recorded detail, visibility only in the extremes, and the same thing with time. So with time, it's directly proportional to exposure. But in this case, what we get is if we have a high mass value, then it may lead to motion artifact. Remember, for testing all the way through the registry, the number one thing that's going to mess up your sharpness or recorded detail that you have no control over is motion. Exactly. You can't control the patient. You can give them good instructions. I mean, you can tape them down if you want to, but if they're moving, they're moving, right? Pigostats, great for holding kids, and I used to use them until I had one almost come out of the pigostat and fly out backwards. Yeah, he was strong, and he wasn't having any part of it. He started rocking that thing, that little leather strap across the back snapped loose. It didn't break it. It snapped loose, so now he's hanging out this thing backwards. Never used another one, because I'm just not having, a 2-year-old land on his head on the floor. So if the patient's going to move, You can't do anything about it, but you can offset that a little bit with time. So if you use a short exposure time, you can limit your motion artifact, right? So going the opposite direction with that, if you use too long of an exposure time regardless, then what you're going to have then is going to be presence of motion artifact. And sometimes we use that to our benefit with breathing techniques, Ottenello method, wagging jaw in the C-spine and whatnot. So has no effect on visibility, again, except for in the extremes. If we have too high mass value, we'll put those two together and our mass value is just off the charts, then we're just not going to see it all that well, right? But again, that's going to be something that you're going to do. I'm not saying you're going to do, but if you lose visibility because of mass, it's because you did something really wrong. You used way too much mass. All right? So, just running back through this, it should be kind of a review for you. Remember, we have two different things that are both 15% issues with KVP. One is 15% change in KVP, and the other is what we refer to as the 15% rule. So with 15% change in KVP, what we get is that increase in production, increase in emission from the tube, but an exponential increase at the image receptor. Patient dose does go up if the only thing that would change the KVP, patient dose does go up, but you're not really going to see a change at your image receptor appreciably. So what you're going to see then is change in your index number. Your index number, if you increase your KVP by 15%, just know that if I go in one direction, the opposite is true, right? So if you increase your KVP by 15%, then what you're going to see on your image receptor is probably not a whole lot of change in the optics, but what you will see is your index number indicates twice as much exposure. So if you're working on a system that, your ideal index number is, say, 200, and you shot an image and you're working on a system where you increase the exposure and the index number goes down, and let's say you shot with an exposure and it gave you 400, that indicates underexposure. Increase your KVP by 15%, and that brings it down to 200. Okay, and again, the opposite is true. If you're working with a system that operates the way, in my mind, it should, you increase exposure, you increase your index number, you would have a double, right? So, again, the KVP used to be what we used to affect a change in our contrast, and thinking about that the characteristic curve, just using it for an example, is if we shot a set of ribs with 75 kVp, then we would have high contrast, as opposed to if we shot a chest x-ray with 120 kVp, it'd be more horizontal, right? High contrast, low contrast. KVP controlled our contrast. All right? So then we have our there's still 15% changes. So all of that, again, it has no effect on sharpness or reported detail, may be a marginal effect on visibility. So then we have the 15% rule, and this is where we're making adjustments to mass. So most of the time your test questions for these two things, just watch for these things. Well, 15% rule truly is this thing, right? So if it says 15% rule, expect to need to change mass. That's number one. Number two is the 15% change is going to be asking you for changes at the image receptor. Okay, because the 15% rule, you have no change at the image receptor. You need to affect a change in your index number. That's the 15% change. This theoretically should not change your index number much, if it changes it at all. Okay, and you can play with these things too. Bring your rib bones. So, with the 15% rule, we have a change in KVP and an opposite change in mass. So it's 15% change in KVP and a change in mass by a factor of 2. So as we increase our KVP by 15%, the same thing happened as what had happened on the last slide, and we got that increase in exposure, increase in emission from the tube, increase in exposure at the image receptor. But if we cut our mass in half, again, we're going to drop our image receptor exposure and even the output from the x-ray tube back down. So what happens is the patient exposure decreases, image receptor exposure remains the same. So what you're going to be looking for in these questions is just that. Same exposure at the image receptor, you want to cut back the patient dose. You need to increase your KVP and reduce your mass, right? Maybe somewhere along the way you may see something that says something to the effect that you need to, increase differential absorption. Increased differential absorption would be, decrease in KVP, so that you would have more absorption in the bone versus soft tissue versus the air. So in that case, you would decrease your KVP, increase your mass to affect that change. Most of the questions that I think you're going to see all the way through the registry are going to have to deal with things like, you made a good exposure on a patient, the index number was right, but then you found out the patient was pregnant and you want to reduce patient exposure. What would you do?
15%.
Increase KVP, reduce mass. Hopefully you won't have to repeat on a pregnant patient, but in that case, or if you're shooting pediatric patients, what kind of techniques are better for pediatric patients? High KVP, low mass, right? So most of the time that you're dealing with 15% rule, that's what you're looking for. You're maintaining image receptor exposure, affecting a change in patient exposure, and usually decreasing that patient exposure. Okay? 15% change, you're changing image receptor exposure. 15% rule, image receptor exposure remains the same. Okay? So, what is it time? Yeah, we're right at 10 o'clock. So that was the technical factors, and that's, you know, how it relates to contrast, sharpness of reported detail, and visibility of reported detail. Really, I don't want to say visibility of reported detail is not really a thing anymore, because it is, especially in, you know, tissue thickness. But as far as your technical factors go, it's just in the extremes. And within reasonable exposure ranges, your technical factors really don't do a whole lot to your visibility functions. Okay, any questions?